Okay, perfect. Oh, great. We're getting good questions already. For those of you waiting, go ahead and put any questions that you have in the Q&A. And we've already started to get some really good ones. So I'm going to do a brief intro, and then we'll dive in. And we have as much time as we need to answer all of your questions today. So there's still more people signing on. Let me give it another couple minutes.
Yeah.
Okay, I'm going to start up and say, welcome, everyone. Welcome to the Lipedema ebook, book, live question and answer with Dr. Erez Diane, and I'm Catherine Sayo. And to say that we're excited is an understatement. This is a long time in coming. It's actually been several years in the making, and the actual writing of it has been a couple of years. So let's see, just a little bit about the Lipedema Project. There's many of you that I know, and you know me really well, but there's quite a few new people coming in. So I'm just going to do a very brief intro. A little bit about the Lipedema Project is a partnership between Lipedema Simplified, which is where I started in 2012, and the Friedman Center for Lymphedema Research and Treatment, which is now at Northwell Health, and is really the generosity of Dr. Mark Smith. Dr. Smith and I have been partnering for a number of years. He's been beyond generous, just supportive and really encouraging as we've moved forward on really creating an agenda. He was the one that that came up with that we needed to create a research agenda and an agenda for lipedema in the healthcare community. So always grateful to him. So who am I and why the heck am I doing this? First and foremost, I have lipedema. I've always had lipedema. Didn't know I had lipedema, and I didn't figure it out until it was too late for me, and I had had 5 surgeries with really dire complications and impending immobility. I have to say that was the turning point for my life and for, oh God, pretty much everything, because the, you know, go left and you end up in a wheelchair, go right, and you don't know what's going to happen, but something's going to happen, and at least there's a chance that it will be a different outcome. So ostensibly, I'm a professor. I teach research. I started to research. I found people who knew something about lipedema, and I traveled around the world with a camera, and I asked lots of questions. At first, it was to help myself. I was really looking for answers. And I have to say, fairly early on, I did find some answers and understood what I could do. But there were 17 million women in the US and many more worldwide that have lipedema. And there was some compelling impulse that I just didn't want anyone else to go through what had happened to me. It's as simple as that. And I said, if there's anything I can do, this will make my, if there's anything I can do to reach even one person, then it would be worthwhile. And so that's how I started. And I have to say why I'm doing this is we are one badass lipedema tribe. I just finished the book, You're a Badass, and it was so great. It was so inspiring. And I thought, yep, that's us, because that's what keeps me doing this. I have some of my dearest friends I've met online. I've traveled through Europe, meeting women that I was in contact with first through Facebook support groups, And they're my dearest friends. You are my dearest friends. You are my tribe. You are my peeps. You are my, yeah. I mean, there's something about having an answer to this lifelong question called, what the hell is going on with my body? And that's really been an incredible opener for me and for many of the women who contact us. So, and I know some of you are some of them. So we're really here to focus on the book. And to say the book is really a summary overview for, we did it specifically for clinicians, though we did have a offering where we made it, the pre-publication version was free to anyone who signed up for it for the first couple months. Many of you received it. It was in process. The very final version is up on the website. You can get it for a donation. We kept it so that those of you who can afford more, that's wonderful. Those of you who can afford less, you can get it for $1. So that's the lowest that PayPal will go. But for a donation, you can get the PDF. It's available on Amazon. It's on iBooks. And Erez and I did the production part of the audiobook, and it will be out. It's in production at audible.com. And so it takes about a week or 10 days for it to actually be available. But it's all in process, and it will be available. We had a little trouble with the Kindle version, but I saw it this morning and it looks great. So Kindle's all set. And the print version, I'll show you in a minute. I have to get out of this in order to do that. Anyway, I'll show you in a minute. Oh, here, I'm showing you now. Here's the print version. It came yesterday. Well, a box from Amazon came yesterday. And oh my God. And I thought it was something. I ordered Vasculera, the European version of Vasculera from Amazon. And I just thought it was that plus a couple other things I had ordered, and I didn't open it. And this morning before I left, I said, let me see what it is. And so I opened the box and it was books. And I was like blown away. My designer and developer said to me, when you see it, it's going to be, she said, prepare, because you're going to just be overwhelmed. And she was right. I looked at it and I went, oh my God, there were so many of us that worked on this. Erez and I really started the ball rolling, but there were 10 other authors. There were literally people from several different countries. I mean, it's interesting. It takes longer to be more succinct. The more precise you're trying to be, the harder it is, and the more time it takes. So it would have taken us a shorter time if it was a 300-page book. But anyway, it's very, very exciting. So I want to introduce Erez and then give him a chance to introduce himself. But Erez and I first met. My very first contact with Dr. Smith was through Dr. Joe Diane, who is Dr. Erez Diane's cousin. You guys are cousins, right?
That's right. Yeah, first cousins.
Yeah, and I had met Dr. Joe Diane through my friend Michelle in the UK, who runs the Lipedema Ladies group in the UK, had told me about Dr. Diane and said, you got to meet with him, blah, blah, blah. So I met with him. So anyway, he invited me down to New York, and I met with them all, and I had dinner with Erez and Dr. Diane. The three of us had a lovely dinner, and at that time, Erez was in the middle of doing a lot of work on lymphedema and had done a lot of the kind of work that we've all done online. He had set up already through Mount Sinai, Beth Israel at that time. And then, as life would have it, he came up here to Harvard, and we reconnected, and Well, here we are. And I have some exciting things to share with you, but he's just, well, what's good is that he's not only a wonderful doctor and a really fine human being, he also loves technology. So we get to do these kind of fun things together. So, Eris, why don't you fill in, and then I'll get some of the questions lined up.
Well, thank you, Catherine. And this, as many of you know, wouldn't be possible without Catherine. I mean, she's absolutely the driving force. We're just kind of, in her bus fueled by jet fuel, just joining her project. So it's really, as you know, Catherine is a force, and Lipedema is lucky to have her really moving things. So as Catherine mentioned, really my interest began thanks to my cousin, who's about 10 years older than me, is a microsurgeon, Joe Diane. He's a leader in lymphedema. And my interest really began in lymphedema. I still have a strong interest in lymphedema. And I think lipedema and lymphedema have been shown to be correlated, especially in later stages of lipedema. And I think that it's kind of naive to study one disease without the other. I would say lymphedema, affects a significant amount of patients, and with especially breast cancer-related lymphedema, there's a lot of focus on lymphedema, but lipedema doesn't really, for many complex reasons, I think, doesn't really get the attention that it deserves. And actually, I think much less is known about lipedema than lymphedema. So from a scientific standpoint, I think there's a much greater opportunity to understand and contribute to this disease process, especially when compared to lymphedema. So I'm really thankful to Catherine for being part of this, and I just think it's an amazing thing what's been put together with all the contributing authors, really world-class authors, and it's just a very exciting time.
Great, thanks, Eris. So our purpose here is really to have a discussion and begin a questions and answers, your questions, and to the best of our ability, answers. And if we don't know the answers, we can find out for you. And also to give you a little bit more information as to what's next. But we'll start with the questions that are coming in. So someone asks, I know that lipolymphedema can make fibrosis. Yes. Is this a concern with surgery? I have had a hysterectomy about 7 years ago, and my surgeon said that my belly had adhesions, as if I had previous surgery, although this was the first one. I now have fibrosis on my calves from the lipolymphedema. Can you tell me what effect the surgery has on fibrosis or scar tissue? I would also be interested to know if abdominal adhesions are common with lipedema. Great question, because it's really wanting to understand the role of fibrosis, especially with surgery and even without surgery.
Sure. So I agree. It's a great question. And I think to clarify things first, you have to kind of define what fibrosis is. And fibrosis is essentially scar tissue, and it can be caused from multiple different things. It can be caused from previous surgery. It can be caused previous surgery is the most common cause of scar tissue, and sometimes fibrosis is a desirable thing. You want scar tissue to adhese tissues together and prevent fluid collections and things like that. In terms of treatment for lipedema, if you mean liposuction, which is the most typical surgical option for lipedema, fibrosis is usually manageable, and what I mean by that is there are different techniques of liposuction that can get through fibrotic tissue. I think there's no question to say that liposuction is more difficult, technically speaking, in fibrotic tissue, but it's very doable. For example, we have two different, so there's typical liposuction, which essentially is a cannula and a suction device. That's kind of the bread and butter type of liposuction, basic liposuction. But as technology advanced, there's different types of liposuction that one may consider using in a situation where the tissue is scarred or fibrotic. For example, ultrasound-guided or power-assisted liposuction, especially ultrasound-guided, functions really to get through fibrotic tissue. In terms of the question of abdominal adhesions, intra-abdominal adhesions, there shouldn't be intra-abdominal adhesions if there wasn't previous surgery there. So I would, I think that a lot of the questions related to lipedema are largely, you can't give a definitive answer because some of them are not known, but I would say the likelihood of having intra-abdominal adhesions secondary to lipedema would be extremely low. So I think it's probably unrelated to a lipedema picture.
Great. Did that answer your question? If you have a follow-up, just put it in the Q&A. So just to let everyone know, you can ask questions in the Q&A section, which you'll see at the bottom of your screen, of the dialog box that we're in for Zoom. And you can also just put it in chat. So, oh yeah, here there's some coming in on chat too. Okay. So someone asks, I have been using a foam chip boot to reduce swelling from lymphedema. I just became aware of it within the last month. It is working for me to reduce the swelling overnight, and then I wear a compression stocking during the day. Is there any research about the boots or foam chip technology? I'm not seeing much info in the lippy community. That's new to me. I have not heard of this before. So, Erez, do you know much about this?
Yeah, so I can tell you a little bit about this. So, lymphedema is, as you know, a difficult disease, and you really have to distinguish. There's two different large categories of lymphedema. There's primary lymphedema, which one is born with or one develops in the teenage years, or it's not caused by a surgical intervention. And then there's secondary lymphedema, which is much more common and typically caused by breast cancer treatment, including sentinel node biopsies and radiation. So first, it's important to distinguish between those two. In terms of conservative treatments, which you're mentioning, there are, of course, compression stockings are very commonly used, and it's important to be measured for them appropriately by a physiotherapist who really is able to measure you appropriately. In terms of boots and this type of technology, the only boot that's really been shown to help are pneumatic compression devices. There are a number of different companies that make them. For example, Pneumatic is one that I know happens to be in Boston that's used by athletes and also for lymphedema. And basically what it does is it has chambers that come up the leg. And as the device works, the chambers progressively tighten, and the ones that just tightened loosen to basically encourage fluid to move more proximally or towards the hip in the extremity, or if it's on the arm, towards the torso, to try to encourage fluid to drain more centrally. So in terms, and the book actually discusses these different treatment modalities for lymphedema as well. So what I would say is it's very important to be plugged into a certified lymphatic therapist that can measure you appropriately for the compression stocking. And also in the book, we mentioned a number of different diagnostic imaging modalities that can help assess sort of where you may fall in the progression of lymphedema. And it also allows you to measure your progress to see how quickly things are progressing or if things are becoming stable visually, which really is a relatively new technology called indocyanine green lymphangiography. I was just working on a different presentation. If you're interested, I could show you some pictures on my screen. But lymphedema is a difficult disease. However, there are treatment methods. Technology is getting better so that you're able to see the lymphatic obstruction and see sort of what's going on. And we're actually doing a study now at Harvard using the pneumatic compression boots with this indocyanine green dye that marks the lymphatics, and we can watch it progress up the extremity with the camera. So it's exciting technology.
It really is. That even in the past 5 years, things have changed. It's really
Absolutely.
So someone asks, I think this is a really good question. I mean, they all are, to be honest with you. But someone says, what is the point of being diagnosed with lipedema? If we seem to have the markers for lipedema, why not just adopt the best practices and live with those practices? I want to, before turning it over to Erez, from a medical point of view, I'd sort of say that one of the points of being diagnosed for many of us is just the relief of knowing that what we've felt has been mainly we're doing something that we could change it, that in fact is a pathophysiological process going on, that there is such a thing called lipedema. And sometimes getting that confirmation of diagnosis from a emotional and quality of life point of view is very, very helpful. The other thing is, if you're considering surgery, and many are, and many have had success, not everyone, but many, is you need a diagnosis in order to move forward for insurance coverage. And the insurance coverage is very difficult. It can be very difficult, let me say, depending on where you are and you know, your insurance company, but you need an official diagnosis for that. So, Eris, I'll turn it over to you.
I mean, I agree with Catherine. I think that for a number of reasons, I think, you know, if you look at social reasons, it's very important to know that this is a disorder, and diet and exercise hasn't been shown to improve it. So knowing that, first of all, how to diagnose it and identify it is the first step. And then once you know that it exists, you know, it's an important thing to know, because then at least you can take steps to treat it, and you won't be misled to think that, you know, maybe I should be exercising and dieting more, and be frustrated with when you find out that doesn't work. So I think from that component, it's important to know. I agree with Catherine. I think from you know, insurance and medical care component, you know, insurances classically have become more and more resistant to covering diseases that exist, and diseases, you know, typically the more high-profile diseases, whether they affect many people or not, are covered, and people have less trouble. So the more awareness is brought, the more awareness that we can bring to a disease like lipedema, the more likely people who suffer from it can be treated and covered. So I think those are what I think are the value of being diagnosed. You know, knowing that it's a disease and not a lifestyle decision, and you know, and especially in America where obesity is a very prevalent problem, really. It makes it much more hard to distinguish from lipedema, but it's an important distinction. And most doctors don't know that even exists. You know, I can tell you, just working on this project and speaking to colleagues, I mean, people just don't know. So it's important to be aware of it, because, you know, you don't want, you know, your primary care doctor, you know, assuming you have obesity and you're just kind of not helping yourself by not dieting and exercising enough, and not being aware that it's actually lipedema.
It's, I want to tag on to what Eris has just said, because one of the things that happened over the past number of years, even before we started working on the book, was that I began to observe that many women had exactly the same story. They would write on Facebook, I've been to my doctor for years. I've continually complained about the pain in my legs, the bruisability that I'm always have black and blue, and they don't listen to me. Or there are different versions of that. This is also in the book, because as we were finishing up, I got an amazing email from someone who said, I went to my primary care to get a referral to a specialist. I brought her information about lipedema, and she told me it wasn't lipedema, it was lymphedema. There was no such thing as lipedema, and I left there crying. And so there's this dissonance between the information that's available right now and the underlying knowledge base. And so what we're trying to do is we're trying to bridge that dissonance. And getting diagnosis actually supports and helps raising awareness, even not only your own, but it also helps in terms of the really the knowledge base, and expanding the knowledge base, which is not an easy task, as you can tell. Yeah. So thank you. There's a couple more coming in, but Kathleen says she's a CLT, a certified lymphedema therapist. And she said, what are the top signs I can discuss quickly with an acquaintance to encourage her to look into lipedema as a potential diagnosis?
Thank you. I think it's a very important question. Diagnosis is really kind of the first step to, you know, to all of this. Lipedema is different from obesity. And in the book, we really outline this nicely. But the way that you differentiate it, there's a number of ways. Some of them are almost diagnosis of exclusion, meaning you would exclude lymphedema, exclude obesity to get to the diagnosis of lipedema. And that's part of the challenge, that, for example, if you have a heart condition, you can draw some blood work and you get some labs and you can really pinpoint it pretty objectively. And lipedema, there are objective findings. For example, usually patients have bilateral fat deposits on both extremities that avoid the ankles and feet, in a pantaloon type distribution, whereas obesity doesn't have this type of distribution. The other thing is you can evaluate the lymphatic system to eliminate or exclude lymphedema as part of the diagnosis, which is typically a confounding variable. So what I would say is the two things are clinical examination and being aware that this fat distribution is a very discrete and classic type of pantaloon fat distribution. And then if it's still unclear, there are other things, other measures and imaging modalities. For example, you can use MRI to evaluate the fluid content of an extremity versus the fat content of an extremity. It's very clear. And we've shown some pictures in the book outlining that. And you can also image the lymphatic system, as we mentioned, using indocyanine green and other imaging modalities to kind of get a better handle of what's going on. So there are a number of different ways between clinical and non-clinical ways.
I just had an email from someone this morning, and I had a very similar situation happen Friday, which is that once you know the typology of lipedema, it's very easy to identify someone who has it, who's probably walking around and doesn't know it. And so the question has been there for a long time. But again, it came up in an email this morning where a woman said to me, I know several women and I think they all have lipedema. What do I do? How do I approach it? And it's a very delicate situation for many of us. So I was at the pool. I do a lot of pool therapy, and I was at the pool on Friday, and there's a woman that I've seen there, and she has lipedema. I mean, clearly she has lipedema. She's stage 3 or 4. And I struggled, and I was in the pool, and I said, well, if I bump into her, if there's an opportunity, well, as luck would have it, after I showered and I went in the locker room, she was sitting right next to where my clothes were. And I said, oh, shit. How am I going to do this? So I ended up, I had heard her in the pool talking to someone about how she was trying to lose weight. So I opened the conversation and I said, I've had a lot of struggle with that myself. How are you doing? So we started a little bit of a conversation, and I never was able to say to her, I think you have lipedema. What I did say is, well, I struggled with my weight a lot. I still do. And even though I did all the right things, I had a very hard time losing weight. And I found out I have this very little known thing called lipedema, which is a fat disorder. So I said that to her, but I didn't say much else. And it's like, again, it's such a delicate thing. And so I wrote back to the woman who wrote me this morning, and I said, we should think of a way to reach other women, but I still don't have the answer. So I'm putting that out to you because I think it's such a good question. And I'm going to sort of lead into, Kathy asks, traditionally, I thought that low-calorie regimes don't work, doesn't respond well to diet and exercise, and that lipedema fat can't be reversed. So this is a really good question because the literature supports this theory that lipedema fat, once it's there, is very difficult to diet or exercise away. Now, that has been to some degree my experience with low-calorie or calorie-restricted diets. But last year, I was at NIH, actually with Dr. Smith. We were at the first conference that NIH held on the lymphatic system. It was September 15, I think. Yeah, that's when it was. So it was a while ago. And I met a woman named Leslyn Keith there who was presenting her research on a ketogenic diet with lymphedema. And I was a bit taken aback because of the success rate. And so a ketogenic diet is low carbohydrate, moderate protein, and high fat. And that's about 180 degrees away from anything we were all brought up on, at least in my generation. And I think up until very recently. And the keto diet was proving to be very successful in her study. In her studies, she'd done a clinical study with it. So anyway, when Leslyn and I first met, we got into a conversation, and I said to her, I wonder if it'll work with the lipedema. And so we sort of pocketed that from 2015 till the summer 2016, when I was in Europe for quite a number of months, actually working on the book. And I put together a summit, and so Leslyn came on and interviewed a woman named Katrina Harris, who's lost 200 pounds. She has lipedema. She was what we would consider stage 3, 4, and she lost 200 pounds in a couple of years on the ketogenic diet. So we started a series of groups last summer. Wow, it's over a year now. And the results have been pretty staggering. The outcomes are way beyond anything that any of us really expected, but women have lost 10, 20, 30, 40, 50, 100, 150, 160 pounds in the past year. And the thing that is also very fascinating, someone posted this morning on the Facebook group, she'd been keto now for 3 weeks, and visibly you could see the inflammation reducing. So her size reduced, even though she hadn't lost weight on the scale. So for those of you who are interested, feel free to email me. There are a couple of groups that we started. There's one called Lipedema and Keto Way of Eating. We're in the midst of putting together a book specific to lipedema and keto. Now, this is anecdotal evidence right now. This is not, we don't have scientific trials yet. There are numerous scientific trials about keto with diabetes, with neurological disorders. Keto was originally used to help those with epilepsy quite a number of years ago. The research in that goes back. I interviewed, Leslyn and I hosted a summit. There's a summit online if you're interested in going in more depth. And one of the people we interviewed was Dr. Thomas Seyfried, who wrote a book on metabolism and works with cancer and ketogenic diet. So the information is beyond fascinating to me. I've been keto for a long time. It's been very, very, very slow for me. But I have other complications. But mostly everybody who gets on it, their results are, like I said, incredible. Do you want to add anything to that?
Well, I think you're probably more of an expert on keto than I am, Catherine. But I think many people, keto is kind of a very logical way to reduce inflammation and reduce fat. Essentially, the way keto works, in a very simplified view, is you're basically starving your mind of identifying the simple sugars and carbohydrates, and then it kind of goes into, and you prevent it from going through it goes through the glycogen, and then you get to the breaking down of fatty acids, which is a very logical, biologically way to reduce fat, and supposedly also reduces hunger cravings as well. So Leslyn will be at the Harvard Lymphedema Symposium in November speaking, so it'll be very exciting to hear her as an expert, as well as speak on this.
Yeah. So just to let, since Eris said it, I'm so delighted to say that he's invited Dr. Smith and I to talk on lipedema. So we'll be at the Harvard Symposium, and Leslyn will be talking about ketogenic and lymphedema and lipedema. So Harvard Symposium. Make sure you support us. there's not much you can do really except send us emails or post on Facebook or something. But we're just
there's going to be a patient symposium that everyone's invited to on November 3rd. The website is harvardlymphaticsurgery.org, so you can go sign up there. It should be a really nice symposium. Catherine's going to be speaking, and a number of other experts in the area of lymphedema. But as we mentioned, these things are related, and ultimately, fat and lymph have a very close relationship, as research has shown. So, take a look. If you're able to come, that'd be great.
And Erez is part of the scientific committee who put the symposium together. So it's really fabulous. So we're having lots of fun points for collaboration. Okay, this is perfect for you, Erez. Has there been any research on CoolSculpting for lipedema?
So first, you have to make sure nobody steals this idea. Because a couple months ago, I remember I was actually in Israel, and I was talking to Catherine, and I said, sometimes you have a light bulb. And actually, I know the guy who invented CoolSculpting. His name is Rox Anderson, a brilliant guy. And the way he actually invented CoolSculpting is pretty interesting. He works at the Wellman Center here at Mass General Hospital. And he noticed that in children who eat ice pops, on one side of their cheek, that cheek has less fat content than the other side. And ultimately, push comes to shove, CoolSculpting was developed, and now it's a very popular, as you know, non-invasive or minimally invasive way to reduce fat. I actually say non-invasive, really. There's no incisions. I was telling Catherine, this would be a great study to do because CoolSculpting has been shown to work. I mean, I think it's fair to say that the outcomes are kind of moderate, but when compared to liposuction. But if you factor in that it's relatively painless, non-invasive treatment, I think it's definitely worth looking into. So we're going to work on an IRB, and we'll look for some volunteers. We have a number of CoolSculpting machines here. Then I think it would just be a very important study to do. So thank you for that question, Susan.
Yeah, that's great. Yeah. I laughed because, when you first mentioned it a few months ago, I said, people will love this. It'll be a good opportunity to see if it works.
Yeah, great idea.
Okay, good. Thank you. Okay, Donna asks, she says, I'm not even sure which of my doctors diagnosed me with lymphedema, but I have had my legs wrapped. Does that mean I do have lymphedema? Also, I'm wondering if a person can have both lymphedema and lipedema.
So that's a very important question, Donna. So, the first question, I guess, for you would be, lymphedema, as I mentioned, can have a primary or secondary cause. So typically, people that have lower extremity lymphedema either had it from like teenage years, for example, and it happened usually on one extremity, usually very rarely happens in both legs. Or there was some kind of operation, sometimes a melanoma, where they had to take a sentinel lymph node in the groin that led to lymphedema or radiation. So the first question would be, which one of those happened? A lot of doctors aren't really attuned to the details of lymphedema, and many are not fully aware of the imaging modalities available. As I mentioned, the indocyanine green has really become the main imaging modality that we use. Am I able to share my screen here, Catherine, or not?
Yeah.
You know what? I'd love to show you guys. It's really funny. I'm actually making we have the major plastic surgery meeting next week, actually, and I'm putting together a talk about this. How would I share my screen?
At the bottom, if you mouse over at the bottom, there's a green folder with an arrow, and it says share screen.
Okay, let me just take a look here.
Just mouse over at the bottom where the mute and the video buttons are.
Yeah. Perfect.
And if you share screen, just share your PowerPoint or whatever you have for your images.
Okay. Do you see me?
Yes.
Okay, so let me just show you. So just as an example, this is, and this image is actually used in the book as well.
Yeah.
This is, what this is, here you see these bright dots, and these are injections of indocyanine green into someone's foot. And this is the normal foot, and this is the foot with lymphedema. So it becomes pretty clear which foot has normal lymphatic channels. And in real time, you can see this kind of pumping. Lymphatic channels have little muscular pumps that pump the fluid upwards. And you can clearly see which ones are disorganized and diseased. So I think, it's a relatively inexpensive test. In the scheme of medical imaging, it's a relatively inexpensive test. And I think that would probably be the easiest way to tell you if you have lymphedema or not. I mean, people who are very attuned to lymphedema can tell you clinically. Lymphedema has a pitting nature to it sometimes in second and third degree lymphedema. So if you press on the soft tissue and there's a pitting, it's a fluid filled extremity. And as we mentioned in the book, there are pictures of MRIs demonstrating a fat versus fluid filled extremity. So you can tell that way too. Also, I would say, if the compression does work, there's a likely, and if you notice that you're using compression and it helps with the fluid, it helps with the extremity in terms of the heaviness and fluid content, there's a good chance that there is lymphedema. Sometimes there's also a potential for a venous issue. There can be a clot in one of the veins that causes the leg to be swollen, but usually that's not a progressive thing. Usually that happens kind of acutely.
Great. Thanks, Erez.
Sure.
Okay, I'm going to, there's quite a number of questions in the queue. So Laurie says, what can we do as a community to make organizations like the National Institutes of Health, NIH, take lipedema more seriously? From awareness raising perspective, that is the purpose of the book. We could have written a book. In fact, when we started 5 years ago, we were looking at writing a book that was patient-facing so that it would be directed towards the patient. And then as we evolved, we realized that without the clinicians on board, it's going to make it much more difficult for those of us trying to get diagnosis and treatment to get it. So it became obvious that this was the best direction to go in. And so the book is really just what it says it is, and is meant as an overview for clinicians. So the more of us that introduce our clinicians, our primary care, vascular, endocrinologists, the interfaces we have, the more that there's going to raise awareness. The other thing in terms of collaborations, the Lipedema Project is collaborating with LEARN, the Lymphedema Education and Research Network. We have done a number of projects together. We have a number of projects in the queue that we're working on. They have quite a broad reach, and both the Lipedema Project and LEARN has collaborated with Erez for the Harvard Symposium, which will be in November. So we continue to make strides. We're hoping that the more and more of we patients who get on board, the faster it will spread, I think. Erez, can you add to that from your perspective?
I mean, I totally agree. I think, in terms of NIH funding, there's a lot of competing interests. And, to be real about it, lipedema, unfortunately, I'm sure falls pretty low on that list of priorities. So I agree with Catherine. I mean, I think all you can really do is spread the word. And I think, for example, I was speaking to Bill Rapici, who's the head of the LEARN organization, about this in relation to lymphedema. And if you look at, for example, there's certain diseases that affect very small numbers of people. For example, the ALS challenge with the Ice Bucket Challenge. And, they've done things to really bring public awareness to a disease that, if you really look at it, affects many fewer people than lymphedema or lipedema.
Yes.
And but they managed to get this social media, and I'm sure that many other people tried for other purposes and it doesn't kind of catch on. But it has to be kind of a social movement to really make lawmakers and the government see it as a priority. And, unfortunately, just like everything else, there's a lot of priorities and not enough money to go around because the NIH deals with everything, from neurologic diseases to GYN diseases to things like this. So there's a million different priorities and there is a budget. So I think just making it, having a stronger public voice would be the key thing.
Yeah, great. Thanks, Erez. There's a lot of questions. Okay, let me go to the chat because there's another question that's been waiting in chat. I would like to know your opinion of the pneumatic compression boot for lipo. I'm assuming that's lipedema. I find it hard to be compliant with wraps. No stocking fits too large. Of course, hard to lose weight. Have heart arrhythmia, so one leg at a time. Keto is just not liking me at all. Any thoughts on this as well? Thank you both. Okay. So there's a couple questions there. I think the main one has to do with pneumatic compression and how can that best be used when there's a comorbidity of a heart arrhythmia.
Yeah. So, in terms of pneumatic compression for lipedema, I think the only time that would really be effective is at a late stage where you have lymphedema as a kind of confounding or additive disease to the lipedema. It's been shown by researchers such as Aaron Green at Harvard and Babak Marara that there is a very close correlation between lymphedema and fat hypertrophy. So as the lipedema becomes more severe, lymphedema sets in as well. And I think in that setting, a pneumatic compression device would be a useful adjunct for the fluid content of the extremity. In terms of heart arrhythmias, truthfully, I'm not an expert in cardiac related things, but I can tell you that there are a variety of different heart arrhythmias, and the pneumatic compression boot should not really affect a heart arrhythmia significantly, in my opinion. But again, I'm not an expert in it, so I wouldn't. That's something I would really speak to a cardiologist about. As lipedema becomes more severe and the lymphatic system becomes dysfunctional and just can't handle the requirement of the extremity to drain, then typically that's a later stage of a disease, and people are looking at liposuction or a functional lymphatic procedure or both to manage it.
So, as somebody asks, and this is sort of a tag on, I think, how do you get the primary care physician to authorize the MRI, since you were just talking about imaging and all of this and how it relates? She says she'd love to give them enough to fight for their right to get the care, because MRIs are not easily prescribed these days.
Sure. No, I think it's a great question. I think, I don't have an easy answer for it. I think that there's a number of factors. So the first factor, most important factor, is finding a primary care physician who, primary care physicians, unfortunately, today are overwhelmed. Mm-hmm. And they're overwhelmed with kind of, I don't want to call them simple diseases, but they're overwhelmed with common problems. So if you kind of present to a primary care physician with something a little out of the ordinary, many of them view it as time consuming and they just don't have the bandwidth to kind of manage it. So the first thing is to find a primary care physician that truly is interested in helping you with this problem and identifies that it is a problem. And I think as Catherine mentioned, part of the book really is to kind of address that and to educate primary care clinicians, because many of them want to be educated. It's just not, something that they have easy access to. So that's one thing. I think, in relation to the previous question, why is it important to diagnose? This is exactly the reason why it's important to have a diagnosis and have CPT codes, because once you have a coding system for a disease, then you can go to the insurance company and say, look, this is a disease, this is the code, it's well accepted, and this is an imaging modality that would be useful. It's complicated. I think that it also depends on, unfortunately, the finances. What insurance company do you have? How easy are they to let things pass through? But what I will say is every insurance company has the option for a peer-to-peer review on every specific case, which means that if you show your doctor this book and demonstrate, and at least they agree with you, that an imaging modality, whether it's MRI or indocyanine green, would be of value in helping a diagnosis, they can speak to someone from the insurance company and get them to have this approved. But it is I don't want to oversimplify it. It is not always easy. I can tell you when I was in training in New York, I don't know how, but they managed to get MRIs approved all the time. And now, ironically, at the Harvard system, it's actually not that easy. And it's not your doctor's fault per se, but it's a combination of the insurance companies and the doctors. And it's a challenge. But, I would say at the bare minimum, your doctor needs to believe that this is valuable and needs to be an advocate. And if not, then you may need to find somebody that does.
Yeah, that's what it comes around to. That's what people have said. Kathy has asked questions, but it's very, Kathy, you're going to have to, write in the chat for me if I'm not getting this right, because you put 3 and I'm trying to piece it together. But she says all of these are untrue, and I think that she's referring to the calorie restriction and exercise don't work, because that the nature of what she's saying is low calorie regime works when it's low carb and it's intermittent fasting. Yes, we've found that to be true. Careful balance between naturally not hungry due to protein fat satiety and starvation, which is unwanted because we're trying to raise, not lower, our metabolism. Yes, the calorie restriction for the sake of calorie restriction, I mean, the research is showing that calories in, calories out is just not what everyone thought it was. And I went to the Blackburn conference this year at Harvard, which is the big obesity conference that happens every year. And the research is clearly showing that what was thought to be low-fat, calorie in, calorie out, calorie restriction doesn't work. Not only for lipedema, but for any kind of overweight or obesity. So, and then Kathy says, diet and exercise do work, but it has to be very specific. And she mentions the work that Leslyn and I have done showing initial clinical results of the ketogenic diet, which is basic low carb with tight insulin and fat storage hormone control, which is exactly what Eris was saying earlier with what happens when the body goes into a fat burning mode with ketosis. So there are those elements. She goes on to say that a professional weightlifter with his own adrenal tumor experience as a youth and knowledge of hormones and now coaches athletes, and someone who reduced from near 500 pounds to athlete using, wait, let me get this. It looks like it's using something similar to what Katrina did. So Katrina lost 200 pounds doing ketogenic, and then she added in weight-bearing exercise. So she did weightlifting as her exercise. And yes, we're not saying at all that that doesn't work. And in fact, I think it's the opposite. But we have historically been told that it doesn't work for lipedema. And something I want to address that Kathy asked is, she says there's a huge gap in the Lipedema Project, Treat FDRS, Learn, and one of the basic researchers is at Harvard Joslin Clinic. Yes, you know, there are, when it comes to diet, there are lots of different approaches. And one of the things that I find that I tell people is not one solution works for everyone. It just doesn't. You know, the Treat and Dr. Herbst, they wrote a book, and theirs is basically the RAD diet. I personally did not find the RAD diet at all helpful. Some people do. If it works for you, fabulous. I was surprised at how powerful the ketogenic diet was. We found that the ketogenic diet is really helping a lot of people. And her last point is Dr. Herbst now believes lipedema stage 2 is reversible. And that and she says that she thinks it can be proven without surgery. With the weightlifter biochemistry lead changed her metabolism from a 17-pound gain-loss cycle for 10 blasted years to a slightly tipped downward line after 18 months of fitness change. I think that this is still, you know, in the works with keto intermittent fasting. And she said she lost 20 pounds in 4 weeks, and I'm focused on breaking the new 10-year metabolic weight set point. This is fabulous, Kathy. We want to hear how you do. I personally think that the thing that's missing for me in my own program is that I've had some mobility issues. It's been a tough year, but I'm getting better. And as soon as I feel better, I'm going to start doing weightlifting again, which I did before. I think weight-bearing exercises has a lot to be helpful for us. Okay, I hope I got all of your points. If not, just write us again. So, Erez, this one is for you. What's the best kind of doctor to deal with this? Diagnose us. It seems
Yeah.
to be no one's specialty other than the surgery route.
It's a great question, and I think there's not a simple answer, unfortunately. There's certain areas in medicine that are kind of dealt with a number of different clinicians that find interest in this. I mean, my training is in plastic surgery. I saw that there was another question about that, but which we can address. But I think finding someone that focuses on this problem is important. So there are primary care clinicians that are aware of lipedema and are aware of the treatment modalities, and would be good to help with this problem. There are plastic surgeons such as Mark Smith, Joe Diane. There's a number of people who focus on this disease and understand it, as well as lymphedema. So it's not really I wouldn't be able to give you a singular specialty that focuses on it, unfortunately. Catherine is probably more aware of who's who in the medical community in terms of lymphedema than I am. So she may be able to help you kind of offline in terms of directing you in your geographic area.
Yeah, we have a directory. If you go to lipedemaproject.org, and under, I think it's resources, there is a lipedema provider directory. And bless Simone Kramer, who is our community maven. She does information like no one I know. She's kept it updated for years now. And so we have a number of people and different specialties. There's Dr. Francis, who is Kathleen Francis. She's in New Jersey, and she's on the board of NLN and the close training that teaches lymphedema therapists. And she's a physiatrist, which is a specialist in rehab medicine. She can diagnose, and she's been very active in the lipedema and lymphedema community. But they're few and far between. Dr. Buck is a surgeon. He's in St. Louis. So there are people, but again, the directory is probably the most helpful place to go. And if you want anything specific, just email me. My email's over everything, and I'll give it at the end of this, our session today. Okay, so someone else says, I agree with you about having the professionals working with imaging and helping me on conservative treatment options. I do not have a diagnosis as I live in Ontario, and despite all of my doctors trying their best, they cannot find anyone who is aware of this disease and can also make a diagnosis. Unfortunately, that is the issue that we're dealing with, and that is the reason why we wrote the book. So the book is an entree, and one of the reasons is that we wanted to have something that was credible, off the chart. You really, I mean, the list of authors, and I consider myself incredibly blessed to be included as part of it, but they're just very credible and hard to say that this is an internet disease with the kind of credibility that this shows. So my doctor is very supportive, but is overwhelmed as there's a huge lack of resources in Canada. This started in puberty for me, so that means I'm going on 40 years trying to find a diagnosis of this, and despite the obvious need for an early diagnosis, my hands are tied. Yes, there is frustration. That's again the reason why we wrote the book. So the book just came out this week. It's just, you know, do whatever you can, get the information to people, and we will continue to work on this. And at the end of this, we have a nice announcement as to a way that will further help clinicians.
Yeah, I agree. I mean, Canada's nationalized healthcare system is a little more challenging. So I just think all the more reason to make more of a push.
And the person who talked about the boot gave me the wrote in the link. If anyone wants the link, I'm going to post it right now in the chat. And let's see. So, Erez, this is how close is acceptance from Medicare giving lipedema a CPT code? Do you have any idea?
I mean, I truthfully I couldn't give you a good answer to that, but I can say that there's a lot of resistance to give CPT codes because once you give a procedure code, and once you give a procedure code, then it almost implies that it should be covered. So there's a lot of resistance to do that just for financial reasons, meaning once you assign a code and diagnosis, and that potentially costs insurance companies millions of dollars. So that you would imagine that they're not so excited about doing that. I think the other thing is that, the problem, at least in plastic surgery, is that liposuction is used for cosmetic purposes as well as for medical purposes. So I'll give you an example. For example, upper eyelid surgery. There are many people in their old age that need to have upper eyelid surgery because their upper eyelids obstruct their vision. And there becomes a gray line between what's aesthetic and what's medical. And, I think in many ways that can cloud the picture here. For financial purposes, it becomes a very tricky thing. So hopefully this book brings us closer to getting CPT codes done and getting this accepted as a disease. But as I mentioned, there are a number of challenges, and one of them being that liposuction is the major surgical treatment, which also happens to be desirable for the general population. So it's a complicating factor.
Yeah, it really is. There have been a number of women who have been very successful getting insurance coverage, and some of the surgeons are willing to do what needs to be done. They have people in their offices. So there are a couple of those who are willing to go to bat with the insurance companies. And of course, it works much better to get insurance coverage the more progressed the disease is. But it takes a lot. There's one woman in LA that I've talked to numerous times. She put together a 180-page document that finally got approved, but took her almost a year to get the approval. So, and then there are others who've gotten it very simply. So it's a crapshoot. I'm sorry. Couldn't think of another expression. So Christy says, I emailed my doctor a link to some information on lipedema so that she could understand my questions when I visited her next. She was shocked by the rolls of fat on my hips and knees, confirmed that I have an abnormal placement of fat, but told me because she didn't know enough, she was unable to diagnose. I was a little surprised when she immediately told me that she could send me to see the on-site plastic surgeon if I wanted. Surely one would need a plastic surgeon who understands this, that this is not surgery for cosmetic purposes. Yes.
Right.
Go ahead, Erez, you take it.
Yeah, so I mean, I think everything you said kind of highlights the problem here. So, it's true that lipedema is an abnormal, abnormal quantity and placement of fat. And it's true that, as Catherine mentioned, I mean, once you know what lipedema is, it's not that hard. You could see someone and it's pretty clear that, this person, the fat stops at their ankles. It's not a subtle thing. It's bilateral. As we mentioned, as far as surgical treatments go, of course, surgical treatments aren't for everybody, and there's a whole spectrum of who are candidates and who aren't. But typically, it's liposuction is a relatively minimally invasive surgical treatment modality, and typically plastic surgeons do that. Although there are, a number of other non-plastic surgeons that do liposuction, which I would be a little bit, or just at least look into their credentials, because there are a number of dermatologists and general surgeons, some of whom are very qualified, but some of whom aren't. So, we spoke about in terms of, liposuction is used for cosmetic purposes. It's basically a minimally invasive technique to remove adipose tissue. And in this case, it's for a medical purpose. It's for a disease. And sometimes to get approval, the plastic surgeon will have to get pre-approval and say, I anticipate to take X number of cc's of fat out of each extremity. And sometimes you need that to get approval.
Great. I want to tag on to this because Judy asks, I have fat deposits medially on both knees. Is this typical of lipedema? Yes. Also, those areas are warmer than other areas. Does this indicate inflammation? I have what I believe is pretty typical fat distribution for lipedema, though never diagnosed. I don't even know where to get a diagnosis. I don't believe my primary would be open to this discussion. Well, again, we're hoping the book will open many doors that at this point may not be open, because even a crack will help you get the conversation going. And Erez, do you want to discuss a little bit about the medial knee issue? Because that's pretty typical.
Yeah, I mean, I agree with Catherine. I think it's typical. I think typically patients with obesity alone don't have, a greater fat deposit in the medial knee. So I think that the book would be useful for a primary care clinician who was open-minded to look at it. Even if, frankly, even if you brought the book to them and showed them just the pictures, there's a number of pictures in there that I think are very instructive in terms of the different stages of lipedema, the classic presentation of lipedema, as I mentioned, the different imaging modalities that can be used. So even if they don't read the book, which, it's fair to say that a fair number of, clinicians may not or don't have the time to, just showing them the pictures during a visit may be helpful. And, if they're not interested in at least hearing your perspective, because, the reality is, medicine is classically, and Catherine's very interested in the doctor-patient relationship, as am I. And medicine has classically had a very paternalistic kind of approach where the doctor tells you what the problem is. But, with internet, it's really been a changing environment. And usually people know what's wrong with them before the doctor does, because in many ways you know yourself better. So if the doctor's not amenable to it, or if they have a different practice philosophy, then maybe it's time to look into someone who kind of meshes more with listening to your concerns.
And we're going to talk about this at the end after we finish the Q&A, because we have some exciting, beyond exciting announcement to share with you. So Laurie, and I hope that's a teaser and that you'll stay till the end, because we are like beyond excited about this. Anyway, Laurie says the key to fasting: when you fast, when you eat, feast, which is Dr. Jason Fung. Dr. Fung has some wonderful books and information on the internet about intermittent fasting. I've been doing a lot of it. I think it's fabulous. So I just highly recommend, if it's something that works for you, give it a try. And Kathy sort of responded to that very long question, and she said, yes, she was talking about heavy weightlifting, fewer lifts, heavier weight, and that it helps, and that she's had really good success with it. And she also said, I have to say, Catherine, you did a great job with your response. Thank you. It was a very complicated question. Okay, this is really great. Laurie just gives a wonderful link to a funding opportunity for a lymphatics and health and disease in the digestive system. I'm going to follow up on that. Okay, let me go to the Q&A. Great. Good question for you, Erez. Can you explain why liposuction helps with pain levels? So many women who have had liposuction will, one of their benefits, they say, is that the pain reduces.
Yeah, so that's a great question. I think one of the explanations, I'll give you an example. When women have large breasts and undergo breast reduction, it's a very common procedure for us. Many of them complain of pain, not only in the back, but also in the breast. And part of the thought process behind that is that there's traction on local nerves. And once you reduce that traction from the weight, the inflammation kind of settles down and you have reduced pain. So part of it is likely related to that. Essentially abnormal weight leads to stress on the nerves and inflammation, and ultimately can lead to pain and discomfort.
Mm-hmm. Good, thank you. Okay. So this is a question about the green dye. how do you say, indocyanine?
Indocyanine green, yeah.
Indocyanine green. Okay. So Dr. Diane has mentioned the imaging with the green dye, the indocyanine green dye. Is that the same as lymphoscintigraphy? And it isn't, but I'll let Erez explain the difference.
Sure. You know what, maybe I'll share my screen again because I have another slide with this. Worked out that we're kind of have this up right now. So can you see me?
Yes.
Okay.
But we're not, now we can see.
Okay, so this is actually lymphoscintigraphy. And basically the difference is that lymphoscintigraphy, they inject a nuclear dye, and it's you go under a machine and basically the nuclear molecule gets excited, and when it comes down to ground state, you get this kind of image. So basically what would happen in an image like this is they would inject your hand, and then a number of hours later, they would go and image you and then show that the dye reached the lymph nodes that are draining the extremity. So basically, this is kind of a static image, and it's a one-time image, whereas the indocyanine green is a more dynamic image, and it happens in real time. So that's the difference. I think lymphoscintigraphy is quickly falling out of favor because it has a number of limitations, and as opposed to indocyanine green lymphangiography, which is much more telling in real time.
Yeah, Dr. Smith had said that as well. Okay, so someone says, what is happening with the research on cause and prevention of lipedema? I can say that we had no research, and then FDRS, in conjunction, in partnership with LEARN, the Lymphatic Education and Research Network, created a number of grants, and those grants are in the process. I think they're in year 2. And so there's movement being done around the genetics, around some of the potentialities for a diagnostic test, and a number of other directions. I did read that the Lipedema Foundation has recently granted a number of other grants. I think there's another half a dozen that went on the list. And if you want to go to, it's lipedema.org, there'll be more information there. And we're looking at the Lipedema project. I mean, I have gotten so interested in the diet aspect and the exercise and diet, because I believe that surgery, while surgery helps, I think surgery helps the earlier your stage. And while it can help in the later stages, I believe conservative treatment can also be very, very useful and may be the first line of treatment. So we're looking at doing some more work with ketogenic and lipedema and to seeing how that does. So Megan asks, as a healthcare provider and a lippy lady myself, how can I connect with my professional colleagues and advocate not only for myself, but also my clients? Many physicians and surgeons don't have the time to really connect with their clients and healthcare providers. Since I wear 2 hats, any suggestion on how to connect with medical colleagues? I so want to advocate for my clients and myself. Yeah. So I think that the more that we collaborate across disciplines, which is the thing that you're talking about, is being able to hold both hats. And I think that's great. Erez, do you want to add to that?
No, I mean, I agree. I think, from a scientific and clinical standpoint, it's an opportunity. I think if you present it to colleagues, especially if you're a physician, and you present this to colleagues as an opportunity to make a real contribution in an area that there's a lot of opportunity to do that scientifically and clinically. Most doctors are interested in that. I think academically minded doctors, and that's part of my interest as well, is to study a field where not much has been done or not much is understood, and your impact is felt much more in those areas rather than, if you were looking into diabetes or heart disease, which is probably oversaturated with people looking into it.
Great, thanks. We have a few more questions. We're going to wrap up in about 10 minutes. So if there are any other burning questions, be sure you get them in. So someone says, does dry brushing or fascioblasting help with lipedema? Do either of these practices hurt or help inflammation? Do you want to?
Yeah, I mean, I to be honest with you, don't know too much about this idea of fascia blasting, but my inclination is that it's probably not a good idea. Fascia is essentially deep tissue. So the way the layers work is you would have skin and then soft tissue, and then at the bottom of that you have fascia, kind of how, when you eat a chicken, for example, there's that white firm layer, that's fascia. And fascia essentially is a tough, fibrous tissue that overlies the muscle compartments. It would hurt if there was any kind of brushing or fascia blasting. I don't see how it would really help with the lipedema, because the lipedema is the fatty tissue above the fascia. So I wouldn't. I can't say I know much about that. I haven't heard much about that, but from my perspective, I don't think it would help.
I'm not, it's an anonymous question, so I'm not sure who asked it, but there is a fascioblasting group on Facebook. I have had the equivalence of some fascioblasting, but it was my physical therapist when I was dealing with a lot of adhesions and scar tissue. She used something called a grafton, which is they do a little bit of digging and they're trying to get the adhesions to disappear. So, but I think that there are places where you can get an answer to that some of the women, I've seen a lot of bruising, but then some women say that it helps. So do go online and check it out for yourself. And Judy asks, anything about the inflammation? Yes. This was the thing that was so surprising when we started working with the ketogenic diet, that for some reason, and I'll tell you what my theory is, the women, even with minimal weight loss, the bloating that was a result of years of carbohydrate eating diminished almost immediately. For anyone who is on the Lipedema and Keto Way of Eating Facebook group, someone posted this morning, she's been doing keto for 3 weeks, and you can see a visible difference in her lipedemic areas. Her legs, her thighs, her knees, significantly in 3 weeks reduced. And I think it's from the reduction in inflammation. It seems like when people get off of carbohydrates, there's something happens. And I feel that for myself. I mean, my history is that I have over 30 years in Overeaters Anonymous, and I went in 1986 with a low-carb diet, and I lost over 140 pounds and have kept it off until the lipedema started to really get wild in my body during my menopause. So I'm a firm believer that, without my knowing it, I got taken care of. I was guided when I started low carb, nobody was talking about low carb. Everybody was like, I thought I was going to lose my hair and my nails and everything was going to fall off. And I didn't know at that time. It was like, in the 80s. So I now am truly convinced that carbohydrates are not good for some of us. Can be good for others, but not for all of us. Okay, Erez, can you speak about the microangiopathic mechanisms occurring during the various stages and how it impacts the reversibility or irreversibility of the progression of lipedema?
Sure. So this is actually addressed in our book. Basically, the etiology and pathogenesis of lipedema is not fully understood, but it is believed to be a multifactorial cause. There have been several theories, one of which, to explain the development of lipedema, one of which was suggested by Foldy and Foldy, who are leaders in lipedema in terms of the science. And basically their findings were that there's an early histological finding of increased permeability of capillaries and fragility of capillaries. And basically it leads to increased leakage of proteins and also increases your likelihood of easy bruising. And the idea is that the fragility of the capillaries is caused by pathological angiogenesis, which is controlled by several factors, one of which is called VEGF, which is an endothelial growth factor. So there is science behind the idea that there's an abnormal angiogenesis that may lead to capillary leakage and protein leakage. In terms of reversibility, I can't say that I'm aware of any. I'm sure that there's a lot of research on VEGF, and angiogenesis is a very large area. So I'm sure that there's research on it, but I don't believe that there's any current reversible treatment modalities for that.
So we have a couple of different questions about leaky gut and lipedema. So I want to say that I found when I was at Blackburn in June, again, Blackburn is the yearly conference that Harvard holds. It's named after Blackburn, who used to do all the fasting at, I guess he was at BI Deaconess at the time, but he's very well known in the obesity world. And they kept saying that there's so much that they're finding about the impact of the microbiome and how it affects everything, and that they felt that while the research is very young, that it's a leading edge kind of understanding that's going to impact everything that we now know about the metabolism and what's going on. Mm-hmm. And then Kathy adds, lazy gut is key to assessing long-stored, hard-to-access glycogen and maintain ketosis, non-insulin dependence, whole-body muscle contraction. Is it T-glute? Lazy. Is it T-glute?
Yeah.
Yeah, okay. Translocates T-glute, the two of 11 most efficient glucose transporters. I don't know this, so Erin, Erez, can you take this? She's talking.
I can't say I'm an expert on any of this stuff, so I wouldn't want to mislead anyone. But as you did mention, Dr. Westman is an expert in this area, and there are a number of nutritionists who really focus on ketogenic diet and the different microbiologic mechanisms. I wouldn't want to comment on an area that's not really my area, but I think we can maybe for the next podcast we bring someone in who's really an expert in this topic, because it is a very interesting area and a very complex area as well.
Yeah, and there is a wonderful symposium that's on the LEARN site, Lymphatic Education and Research Network site. Dr. Westman gave a symposium on lipedema, lymphedema, and keto, and Leslin did as well in July, I think it was. But they're there and the replays are there. Okay, so let me see. There's one or two more things to hear. Someone joined late, wants to know if they could watch a recording. Yes, there's going to be a recording, and I'm probably going to put it in the group, in the lipedema and keto group. I know, we have a discussion group on Facebook, and it'll probably go there. Great. Someone wants, Erez, can you spell Indesign green and put it in the chat? Okay. And the last couple of questions. Megan says, yes, there's more blood and lymph that is drummed up. I think this is about the fascioblasting, and our lymphatic system is compromised for sure. So that's good to know. She's a practitioner, and she's saying, okay. So this is the last question I have. With a family history of heart disease, can I safely switch to a keto diet? A chef friend with MS has had great results, as has had another friend with diabetes. Yes. The interesting thing that they've found, and this is, please, Christy, you can contact me and I will give you a discount if money is an issue for you, so that you can listen to some of the summit interviews, because it really goes in great depth about what happened and how we moved into a low-fat world, when in fact it's the worst thing, because it's carbohydrates and sugar that exacerbates heart condition.
Right.
All right. So, okay, going once, going twice. Any other questions?
Someone here I see has a question about self-prescribing compression garments.
Yes, good.
You know, I think it's actually an interesting idea. I would suggest that, you know, ideally there's a formal diagnosis of either lymphatic disorder or lipedema. I wear compression garments almost daily, just because when I'm operating, I feel that my legs get swollen, and so there are compression socks available, kind of commercially. I think I don't think there's any harm in wearing that. I think that, you know, if you stand for long periods of time, even if you don't have any disorder, it's helpful to reduce fatigue and fluid accumulation. But you know, if there is a problem, it's very useful to be seen by a physiotherapist who really specializes in these areas and can give you the most effective garment. There's many different types, and you know, sometimes you really have to kind of test them out and see what works for you, because they can be very uncomfortable, especially in hot temperatures.
Mm-hmm. Yeah, but you can't hurt yourself by wearing them.
I don't think you could hurt. You wouldn't hurt your lymphatic system, so to speak. You know, the only reason I hesitate on that answer is because the idea is to do it in a progressive fashion. So the last thing you want to do is cause a tourniquet type effect on your extremity, and
Yes.
some people do that unknowingly.
Mm-hmm.
You know, so that's my only hesitation. I've seen people that sometimes do it only in one part of their body, and it almost functions as a tourniquet, and it can it can be very problematic if you reduce venous. There's a venous outflow component to every extremity, so you want to be careful not to compromise that.
Yes, that's good. Thanks for pointing that out. It's actually accurate. So be sure to get a consult, or even just see they have fitters that can help you get fit for compression.
Right.
Okay. So we hope that this has been great. And so ask me about my podcast. Ask us about our podcast. This is really the beginning of something. So this is when Erez and I were doing our the audiobook. And there's a studio which is connected to Harvard over in Cambridge. It's the Podcast Garage. And so we decided that we're starting a podcast. We had so much fun with it. So there's the podcast wall, and there's us on the wall. So we began with Who Does the Healing? Clinician-Patient Connection, and we actually changed it to the Doctor and Patient Connection. Who is the healer? So the podcast is going to start up in the next couple of weeks. Actually, I'm going to Italy, so it's probably going to be when I get back from Italy, unless we can figure out a time to get in the studio. We're going to get our calendars together. But we've started to get some very interesting people, and it's really looking at the change in healthcare. That one of the things that's come out of all of this work with lipedema is how much of the movement that we've had has come out of doctor and patient partnerships and collaborations, and that there is a wonderful trend in being able to jointly come to solutions. And so Erez and I both got really excited about it.
Yeah, no, I think it's a great, it's all about partnership and having, an interface between, one of the biggest complaints patients have is not enough time is spent, or doctors aren't communicating with each other. It's a very prevalent problem, and it's easy to point the finger at the doctor sometimes, but it's really the system that's the problem. So hopefully we can do something to change the system a little bit.
So please, come to the podcast. Right now, there's a Facebook discussion group. We're going to be having experts coming into the Facebook group. Unlike most Facebook groups are patient-only discussion support groups. This is a discussion group around the book, but really it's around lipedema. And we'll have, Erez will be there, but so will several other experts answering questions and helping and being part of the discussion. So that is on Facebook. Wait a second. I didn't put the link. I thought I put the link. All you have to do is put in the title of the book, Lipedema, the Disease They Call Fat, an Overview for Clinicians, and it's a discussion group, and you'll go right, it'll take you right to it. Any information on all of this, go to lipedemaproject.org and then /ebook. It has all of the information about the ebook, or email me. There's my email, and that's it. It's a wrap.
Thank you, everyone, very much. And thank you, Catherine, especially.
Yeah, thank you. It's a wonderful partnership. Good, we're getting great comments. Love this, thank you. Compression socks can cut off lymphatic drainage for lippy ladies. Good to know. Okay, yeah, Megan mentions the whole tourniquet thing as well. Okay, let me check. Thank you, thank you, thank you, thank you, thank you. Love, love. Thank you. Erez, as always, a pleasure.
Thank you, Catherine. You're amazing.
Thank you, everyone. Many blessings.
You.
May your Sunday be blessed. Okay, we will all see each other soon.